Alright, today we're going to talk to you about Module E, heart failure, congestive heart failure. This is going to be the first thing in the cardiac that we're going to go over with you. Now, just to give a little overview, we're going to do a little A&P overview, talk about some important terms and concepts, also look at heart failure clinical reasoning case study. Now the case study will be covered during class, so if you're coming to class, hopefully you are, you need to print that up and make sure you bring it with you so you can be able to discuss that. Now let's look at blood flow through the heart. Now the heart's divided into two separate pumping systems, the right side of the heart and the left side of the heart. Now the proper cardiac functioning requires that each ventricle pumps out equal amounts of blood over time. If the amount of blood returned to the heart becomes more than either ventricle can handle, then the heart can no longer be an effective pump. So if you look at this, you see how the blood comes into the system, how it leaves, where it goes. You need to be familiar with all those. I'm not going to go through the A&P things again. We'll just briefly go over that. Now, anatomy review, like I said, we'll talk about that a little bit. The venous system starts with the vena cava, goes to the right atrium, through the tricuspid valve, the right ventricle, the pulmonic valve, and then the pulmonary artery to the lungs. It's then returned via the pulmonary vein to the left atrium, through the mitral valve, through the left ventricle, through the aortic valve into the aorta, and that in turn goes to the arteries, tissues, and veins. Now remember, your venous system is going to return to the heart what kind of blood? Oxygen depleted blood. Then it goes through your heart, goes to the lungs, gains oxygen, and then is pumped out, comes back to the heart, is pumped out to the rest of the body to provide oxygen to the tissues and organs and everything in your body. Now electrical conduction is done through your SA node, goes to your AV node, then to your bundle of His, your left and right bundle branches, your Purkinje fibers, and that is where you get your PQ RST waves on the EKG. Now your electrical current comes first, and then the muscle contracts or relaxes afterwards. Now heart failure is basically excuse me there for a second. Heart failure basically is an interference with the normal mechanisms that regulate cardiac output. Now let's talk about preload. Preload is the filling pressure of the right ventricle and left ventricle, and it's influenced by the venous return. Now higher venous return and blood volume in the atria equals the higher volume, the higher the stroke volume will be, and the opposite is also true. Now pressure and stretch is basically caused by the amount of blood remaining in the ventricle at the end of diastole, or the blood pressure in the left ventricle at the end of diastole. So some things I want you to think about are what cardiac meds most strongly influence preload. And I also want you to think about how will volume depletion, such as dehydration or blood loss, affect preload. Now let's look at your stroke volume. Also, the amount of blood that's ejected from the ventricle with each contraction is basically your stroke volume. Systole is basically the contraction. The myocardium are tightening and shortening. Contractibility, some heart failure terms, is basically how well the muscle works, how well the muscle of the heart contracts and relaxes. Now, your afterload is the force of resistance that the left ventricle has to generate to open the aortic valve. It correlates with your systolic blood pressure. Now, during afterload, your atrial vasodilation will decrease. It's important when an acute myocardial infarction happens, we need to decrease the workload of the heart by intentionally lowering the afterload. Now, nitroglycerin indirectly affects afterload through decreasing preload. Now, some things I want you to think about are what meds work on the afterload. Okay, beta blockers, ACE inhibitors, calcium channel blockers, atrial vasodilators such as hydralazine. What would epi do to an afterload? That's some things I want you to think about. Now, during diastole, the muscle fibers lengthen and the heart dilates and the cavities fill with blood. So some other heart failure terms. Hypertrophy is basically the increase in the size of an organ or structure. And it's referred to when the heart is enlarged as ventricular hypertrophy. Ventricular remodeling is the changing in size or shape of the heart. Cardiac output. This is a formula and you're not going to have to figure this out, but just know that cardiac output is the heart rate times the stroke volume equals cardiac output. Now, a definition of heart failure is basically an abnormal clinical condition involving impaired cardiac pumping. Now, it results in the characteristic changes of vasoconstriction and fluid retention. And basically, it's like a car where the timing is off, and basically it doesn't run smoothly. It's out of sync. So, about 75% of all people with heart failure is caused by hypertension. That's why it's important to make sure that we control hypertension, to try to get that under control. Now, some different causes of left-sided heart failure. These are going to be like aortic stenosis, and that's basically where the increased volume to pump from restricted blood outflow. Cardiomyopathy, which is basically increased workload from impaired contractibility. Coarctation of the aorta, which is restricted outflow and increased resistance from the narrowing of the aorta. Hypertension basically is resistance increased from elevated pressure. It can be caused by a heart muscle infection, and this increases the workload from the damaged myocardium. Also, a myocardial infarction can do this. That increases the workload from the impaired contractibility. And then mitral regurgitation, which is basically increased volume to pump from backward blood flow. Now, some causes of your right-sided heart failure. Is basically atrial septal defect. That's basically where your left atrial blood flow to the right atrium increases and the right ventricular volume causes the right ventricular volume to pump. Cor pulmonale, which is resistance increased from elevated pressure. Left-sided heart failure can cause resistance increased from backup fluid and elevated pressures. Pulmonary hypertension, where resistance is increased from elevated pressure. Pulmonary valve stenosis, where there's increased volume to pump from restricted right ventricular blood outflow. And heart failure can be the result of systolic dysfunction diastolic dysfunction, or a mixed systolic and diastolic function. Also, systolic dysfunction is a contractual problem in which the ventricle is unable to generate enough force to pump the blood from the ventricle. Diastolic dysfunction is a problem with the ventricle's ability to relax and fill. Now, a mixed systolic and diastolic dysfunction is a combination of two defects. Now, these problems influence the preload and the afterload of the heart. So let's look at heart failure, how it happens with right-sided heart failure. Basically, you have an ineffective right ventricular contractibility. This basically reduces the right ventricle pumping ability. It decreases the cardiac output to the lungs. So there's blood backup into the right atrium and peripheral circulation, and this causes weight gain, peripheral edema, engorgement of the kidneys and other organs. Now, your left-sided is going to be ineffective left ventricular contractibility. You're going to have reduced left ventricular pumping ability, decreased cardiac output to the body, blood backup into the left atrium and to the lungs. You're going to have pulmonary congestion, dyspnea, and activity intolerance. And you're going to have pulmonary edema and right-sided heart failure. Now, some things to remember. Right-sided heart failure, you're going to have more, you're going to be able to see the water weight gain, so you're going to have weight gain, edema, they're going to have pitting edema. Left-sided heart failure, they're going to have pulmonary, so their lungs are going to sound wet, they're going to have problems breathing. If it gets really bad, they can have pink frothy sputum. So those are some things you want to watch for with left and right-sided heart failure. Now, some mechanisms that occur in heart failure. Basically, when the heart begins to fail, the body activates several defense mechanisms in an attempt to maintain your cardiac output and your O2 to the vital organs. Now, your sympathetic nervous system stimulation is the least effective compensatory mechanism triggered by decreased cardiac output. Now, this produces venous and arterial vasoconstriction, increases the resistance or afterload, and increases the myocardial workload. In addition, your sympathetic stimulus reduces renal blood flow, and the kidneys respond by activating the renin-angiotensin system, causing sodium and H2O, or water retention, The increase in blood volume and the increase in myocardial oxygen demand on an already compensated heart. So your renin-angiotensin basically reduces flow to the kidneys, activates your RAS, your vasoconstriction is pronounced, and you have an increase in aldosterone secretion, and this causes sodium and water retention. Now, your angiotensin 2 contributes to ventricular modeling, causing myocardial cell contractual dysfunction over time. Now, let's talk about nucleic peptides, such as your BNP. This is basically a hormone that promotes vasodilation and diuresis through sodium loss to counterbalance the RAS, or the renin-angiotensin system. So, somebody that has usually a BNP is high, that means that they're having congestive heart failure, because they produce more nucleic peptides to deal with the RAS. Now, ventricular hypertrophy basically represents an increase in myocardial muscle mass and cardiac thickness, and this is an attempt to increase cardiac output. Now the heart works harder, so the myocardial oxygen demand increases also. Now your cardiac decompensation occurs when the heart is unable to meet with the metabolic demands, and that's when CHF develops, or chronic heart failure, congestive heart failure, excuse me. So some diagnostic tests that are going to be used to determine CHF. We talked about your B-nucleic peptide, or your BNP. Now 95% of BNP resides in the ventricles. As pressure increases in the ventricles, this is going to increase also. And that's when your BNP is released. Now it's released when excessive stretching is present in the ventricles due to the excessive end diastolic filling pressures. It also works as an ACE inhibitor. It causes rapid diuresis. It inhibits aldosterone and renin secretion, and it works as an antagonist to angiotensin II, and inhibits the release of norepinephrine. Now, like we talked about, BNPs are used to diagnose and also assess the response to treatment. Now, your normal BNP is going to be less than 100. Elevated is usually 100 to 500. And if it's a CHF exacerbation, it's usually going to be greater than 500. Also, another diagnostic test they're going to do is a echo or echocardiogram. They're going to look at the ejection fraction, how well the heart is ejecting the blood, and that will tell them how bad the heart failure is. Now, there's different types of heart failure. We're going to talk about systolic versus diastolic. Now, systolic is the most common cause of heart failure. It's the inability of the heart to pump blood forward. Now, your left ventricle loses the ability to generate enough pressure to eject the blood forward, and over time your left ventricle becomes enlarged, dilated, and has a decrease in the ejection fraction. Now, this is caused usually by hypertension or a primary disease of the myocardium called cardiomyopathy. Now, your diastolic is basically the impaired ability of the ventricles to fill during diastole. Now, that's why cardiac output is impaired, and it impairs your stroke volume. Now, this can have a normal ejection fraction, diastolic heart failure can, when the enlarged left ventricle, when there's an enlarged left ventricle but a normal ejection fraction, and respiratory complications on the left side, heart failure diagnosis is made. So when there's an enlarged left ventricle but a normal ejection fraction, and they're having respiratory complications, then there's a diagnosis of left-sided heart failure that's being made. Now, talk about left-sided versus right-sided. Left-sided is the most common heart failure. It has a direct relationship with systolic heart function, and this is seen from left ventricular dysfunction, which causes, again, a lack of forward flow and causes the blood to back up in the left atrium and the pulmonary veins. Now, this increased pulmonary pressure causes fluid to leak into the alveoli, causing respiratory complaints that are usually seen with pulmonary edema. And remember, we talked about pink frothy sputum is when they have a lot of fluid back up into the lungs. Now, systolic, like we said, refers to ventricular dysfunction. And your right-sided, now let's look at left-sided. You're going to have usually caused by hypertension or an MI or cardiomyopathy. Your right-sided can be caused by COPD. So some things I want you to look into, and some of the cartoons that I posted on the blackboard will give you an idea of left-sided versus right-sided heart failure, the signs and symptoms, also some of the medical treatments and nursing care that needs to be done. Now let's look at a case study. Now Mr. Kelly, it's been 3 years basically since he's been discharged from the hospital for coronary artery disease and also a myocardial infarction. He's now 56 years old. He's not had any reoccurrent chest pain, but has had to sleep with 3 pillows to keep from becoming short of breath at night in the last 2 weeks. Now he's had difficulty getting his shoes on for the last month because of increased swelling around his ankles. He forgets to take his medications every day, but does take it at least 4 to 5 times a week. He weighs himself about once a week, and his total weight has increased from 255 pounds to 264 pounds in the last 7 days. Now he's made an appointment through his clinic because he's been concerned about his shortness of breath at rest, and he's getting more fatigued during the day. Now the clinic physician recognizes that he'll need acute inpatient care, and he coordinates a direct admission to the hospital by EMS. So let's look at his current status. Mr. Kelly arrives to your telemetry unit. You're a telemetry floor nurse. You just received him as a direct admit. You review his history through the electronic medical record, and the paramedics relate the above story of why he's being admitted. So let's look at his vital signs. His temperature is 98.4. He's got a pulse of 126. It's regular. His respirations are 28 and labored. Blood pressure is 184 over 104, and his O2 sats are 90% on 2 liters. Now some other things you assess, and you find his cardiovascular system. He's pale, cool to the touch. His pulses are +2. He's got 2 to 3 plus pitting edema in the lower extremities. Respiratory, you hear coarse crackles scattered throughout both lung fields. His labored, you also see that he has a labored respiratory effort. Neuro, he's anxious. He is alert and oriented ×4. His GU-GI is within normal limits. So what data is important and relevant that has a significant clinical clinical significance to the nurse? So let's look at this. His heart rate's 126. He's also pale and cold to the touch. He has 2 to 3 plus pitting edema. He's got crackles in both lungs. His respirations are 28, which is a little bit increased. He also has a labored respiratory effort. Now he's on 90%. His sats are 90%. He's on 2 liters nasal cannula. He's also feeling anxious. So let's look at why these different things are happening. Your heart rate, his heart rate's 126. He's pale and cool to the touch. His sympathetic nervous system stimulation is kicking in to maintain cardiac output. Remember, cardiac output equals stroke volume times heart rate. Now, the 2 to 3 plus pitting edema is caused by fluid volume overload with left-sided heart failure, transferring over and causing biventricular failure, both left and right-sided heart failure. Now, the coarse crackles in both lungs is because of increased hydrostatic pressure in the pulmonary vessels due to left-sided heart failure that results in fluid in the alveolar space. His respiratory rate of 28 is labored, and it's because, just like we talked about the crackles in the lungs, also the 90% on 2 liters. Now, the anxious feeling is most likely related to hypoxia, also to the respiratory distress. That's probably going to lead to acute pulmonary edema secondary to heart failure. Now, based on the data that you've collected, what's your primary concern right now? Okay. If you answered his oxygen, then you're correct. It's obvious that he's in respiratory distress, and that has to be addressed. But you also have to address the underlying cause in order to remedy it effectively. Now, you need to immediately decrease the workload of the heart by getting rid of excess fluid volume. So you want to reduce the preload. Now, what is the underlying rationale or patho of your concerns? And basically, it's because there's fluid volume overload that needs to be addressed so the heart is able to maintain this pace, or it's going to get, his heart's going to wear out, basically. What you want to do is you want to lower afterload and systolic blood pressure. You also want to have diuresis to try to do that. Now, what medical or nursing interventions will you initiate based on the priority concern? So, what kind of interventions are we going to do for this patient? Well, most likely for preload reduction, they're going to try to do aggressive diuresis. Usually this is done by a loop diuretic such as Lasix. You also want to reduce afterload, and this is going to be accomplished now, your afterload reduction is going to be accomplished through medications that directly or indirectly lower your blood pressure. It could be a nitroglycerin drip, or it could be sublingual nitroglycerin or a patch, depending on the severity of the fluid. Now, nursing interventions are going to focus on the need for frequent assessment of the response to these therapies. So you're going to look at their urine output, their systolic blood pressure, also the respiratory assessment. So you're going to listen to their lungs. You're going to see, are the crackles getting better? Are they able to breathe easier? Now, is there any more nursing assessment data or information that you're going to need? You possibly could do a 12-lead EKG. This is going to be essential to determine if there's the current decomposition was influenced by an acute MI, or is it a primary just from the heart failure? Now, what are diagnostic statements? What nursing diagnostic statements will guide your plan of care, and what will your interventions be based on this concern? So, let's look at some things you could develop a nursing care plan. You have impaired gas exchange. Now, this can be You're going to increase the O2 to at least 4 liters. You're going to assess their response. You're going to continually monitor their O2 sats. You want to frequently monitor their respiration rate and their respiratory status. You're also possibly going to put them on a cardiac monitor, ensure their patency and adequacy of the monitor. Another nursing diagnosis would be excess fluid volume. For this, you could contact the MD, make recommendations to the physician. You also might want to consider them having a Foley, since they are going to be diuresing a lot. Ineffective cardiac tissue perfusion is another one you could have. This type of thing, you're going to monitor their heart rate and blood pressure, so you can watch their afterload and try to reduce it. You also need to want to decrease the workload of the heart. So, besides Lasix, what other meds are you going to need? Probably nitroglycerin as a drip. Their anxiety, you want to try to relieve that. You could do that with morphine or Ativan. Now, what's the worst possible complication to anticipate? This patient, if the treatment doesn't go well, they're going to deteriorate, and they're probably going to possibly require a BiPAP or possible intubation to prevent any kind of respiratory arrest. Now, what nursing assessments will you need to initiate to identify and respond quickly if a complication develops? You're going to assess their respiratory rate and the effort of breathing. You also want to assess their heart rate and look for any dysrhythmias that may be present. You also want to assess their O2 sats and the amount of oxygen that they're needing. You also want to look at their breath sounds, listen to their breath sounds, and see how those continue. Now, let's look at what type of heart failure does Mr. Kelly likely have based on his previous documented history. So, probably biventricular, left-sided initially, that progresses to right-sided heart failure. You need to compare and contrast the patho and signs and symptoms of the left-sided versus right-sided. Like I said, look at those cartoons. That'll help you out some. What are the clinical manifestations? What other clinical manifestations did Mr. Kelly present with that are consistent with biventricular heart failure? So he had fatigue, weakness, orthopnea, edema, fluid retention, shortness of breath, all those things. And what are the other manifestations that also can be seen in heart failure? So chest pain can be seen, behavioral changes, and that can cause increased restlessness or confusion. So, left-sided heart failure, let's look at that. Acute pulmonary edema. This is caused by left ventricular failure in patients with severe decompensation. It is a medical emergency because it can cause death from suffocation if untreated. And basically it's caused by elevated capillary pressure within the lungs. So the fluid is pushed from the circulating blood into the interstitial tissues, then the alveoli, bronchioles, and the bronchi. So basically the water builds up in the fluids, and we talked about suffocation, they're going to drown is basically what happens in their own fluids. Now let's look at your nursing assessment of left heart failure. Your S3 occurs at the end of the rapid filling period of the ventricle during the beginning of the ventricular diastole. And S3 if heard, should occur 120 to 170 milliseconds after S2. A patient could have left-sided S3, and this is best heard at the with a stethoscope at the apex of the heart while the patient is in the left lateral decubitus position. Now, right-sided S3 is best heard with the bell of the stethoscope over the tricuspid region, with the patient in the supine position during inspiration, or both. Now, an S3 can either be physiological or pathological. Now, a normal S3 is common in children, young adults, sometimes from ages 35 to 40. Also, women in their third trimester of pregnancy. Now, an abnormal S3, and that's usually in S3 that's heard in anybody over the age of 40, is usually associated with decreased myocardial contraction, myocardial failure, or it could be from volume overload of the ventricle, such as a mitral or tricuspid regurgitation. Now, with left-sided heart failure, you're going to have dyspnea, cough, bilateral crackles, can cause orthopnea, pulmonary edema. Like we talked about the S3, and this sounds like Kentucky when you're listening to it. Can cause confusion, fatigue, and muscular weakness. Nocturia. Also, increase the retention of sodium and water due to the lowered glomerular filtration, and this causes edema. Now, there's 4 factors that primarily influence cardiac output. Those are bradycardia, tachycardia, decreased volume, and increased afterload, and that's usually caused by hypertension. So, some signs and symptoms, some things that are effective on the system. In the brain, you're going to see changes in the level of consciousness. In the heart, they could possibly have chest pain. The lungs, you're going to listen for crackles, look for shortness of breath. Their skin is usually going to be cold and clammy. Their kidneys, you're going to see a decreased urine output. Their peripheral pulses usually are going to be weak and thready. Their blood pressure usually drops. They can become dizzy and faint. Now, arrhythmias are no big deal until they affect the cardiac output. And that's going to be things such as VTAC, VFib, or asystole. So, nursing assessment of right-sided heart failure. You're going to have dependent edema. That's usually an early sign. It's going to be symmetric. If they're on bed rest, you're probably going to see sacral edema. Anasarca can be a late sign of CHF. Also with men, you could see scrotal edema. They can also going to have ascites. They possibly could have ascites. Weight gain is usually going to be greater than 2 pounds a day. Now, what type of heart failure did Mr. Kelly likely have based on his previous documented history? Remember, we talked about biventricular. So treatment for heart failure, basically you're going to use different things here. You want to increase cardiac output, you're going to use inotropes or beta blockers. You want to force the ventricular contraction, but decrease the rate of ventricular contraction. the different things you're going to use. Nitrates will dilate and also decrease preload. Your diuretics are going to decrease in intravascular volume. Your ACE inhibitors are going to dilate the arteries and decrease afterload. So some medical management of heart failure. Basically, you're going to update the cardiologist. So we're back to Mr. Kelly. You're going to update the cardiologist on your floor and tell her about the history and the current assessment findings. Now she orders the following medications: Lasix 40 IV times 1, Nitrodur patch 0.4 milligrams topically, digoxin 0.25 milligrams PO, hydralazine 10 to 20 milligrams IV as needed for systolic blood pressure greater than 150, and lorazepam 1 milligram PO every 4 hours for anxiety. So let's look at what are the rationales behind each one of these medications that she's given. So the furosemide is basically Lasix. It's for aggressive diuresis. They want to get rid of the volume quickly. The Nitrodur is a venous dilator, so you want to displace excess volume through decreasing preload. Your digoxin is going to improve your cardiac output by increasing contractibility. Your hydralazine is going to decrease the workload of the heart through afterload reduction. And your lorazepam is basically going to decrease anxiety and decrease their heart rate, which will decrease the workload of the heart. So let's look at each medication individually. Your furosemide, and we know it is a diuretic. The action basically inhibits sodium reabsorption in the loop of the Henle, and it excretes water, sodium, potassium, and magnesium. Now, some things you have to look for: side effects or hypotension, low potassium, magnesium, and sodium levels. Your nursing implications. You're going to assess for fluid status, your I&O, daily weight. You're going to monitor their electrolytes, also their blood pressure, and you also want to look, if they're elderly, you're going to make sure they're not a fall risk. Patient education, you want to let them know that there could be orthostatic changes in their blood pressure. You also want them to be eating foods that are high in potassium if they're on this for any length of time. Now, Nitrodur, we know it is a vasodilator. Its action, basically, it dilates coronary arteries, vasodilates the venous arterial greater than the arterial system. A preload or afterload reducer. Which one is it? It also decreases cardiac oxygen consumption. Now, your side effects are going to be dizziness, headache, hypotension, and tachycardia. Your nursing implications, so you're going to need to monitor their blood pressure and heart rate closely. After you give it, you also want to rotate the patch sites daily and take it off at bedtime. Now, your patient education, you want to let them know that they're at risk for orthostatic hypotension, that headaches are common. If they're taking tablets, those should be replaced every 6 months. And they also want to avoid getting those in any kind of heat or humidity. Now, your digoxin, basically it is a cardiac glycoside. Its action, it increases the force of the myocardial contraction. It is a positive inotropic effect. It slows the AV node conduction. Now your side effects, it could cause fatigue, bradycardia, anorexia, also nausea and vomiting. Your nursing implications, you want to monitor their apical pulse. One hour before you give it. You want to hold if their heart rate is less than 60. Patient education, you want to make sure that they know to take their pulse before taking it, and they need to hold it if their heart rate is less than 60. They also need to know the symptoms of digoxin toxicity. Now your hydralazine, it is a arterial vasodilator. Its action is basically a direct acting peripheral arteriolar vasodilator. Side effects, you're going to have tachycardia. Nursing implications, you want to monitor their blood pressure closely after giving. Patient education, you want them to avoid any type of sudden orthostatic changes, because that could cause them to pass out. Your lorazepam is basically a benzodiazepine. Its action, it depresses the central nervous system. Side effects can be dizziness, drowsiness, or lethargy. Your nursing implications, you're going to assess their level of consciousness closely. Patient education, you want them to avoid any kind of alcohol with medication. They need to avoid driving or any kind of activity requiring alertness until the response to the medication is determined. So, I want you to do a little bit of math here real quick. So we're going to give furosemide. We got to give how much? How much furosemide was ordered a while ago? Okay, so it comes in a 20 milligram per 2 liters, so 20 milligrams in every 2 milliliter vial. Now, what volume are you going to administer? I also want you to figure out what time frame you're going to administer this, and how much volume every 15 seconds. Okay, I'll give you a few minutes to figure this out, and then we'll talk about it. Okay, so what will the volume be that you're going to administer? So the doctor ordered 40 of Lasix. We know it comes 20 milligrams in 2 mLs, so we're going to give 4 mLs. Now, over what time frame? So Lasix, you can give how much? Every minute. Okay, you can give 20 milligrams every minute. Okay, so you're going to give it over 2 minutes. Now, how much volume are you going to give every 15 seconds? So think about it. 15 seconds. You're going to divide. We know we can give it over 2 minutes, so you can give 20 milligrams every 2 minutes. Right? You're going to have 4 mLs. So, you're going to be able to give half a milliliter, every 15 seconds. Alright, so you've been assessing Mr. Kelly every 15 minutes for any kind of change in status. Now, after receiving all these medications, 1 hour later, he's resting more comfortably. He's got fine crackles that are present in the bases, and he's diuresed more than 700 mLs of urine. His vital signs at this time are currently, his pulse rate is 82, respirations are 20, blood pressure is 136/88. His sats are 95% on 4 liters nasal cannula. So, a couple hours later, Mr. Kelly puts his call light on and notifies you that he feels palpitations in his chest, he's feeling lightheaded, and that his heart is racing. He appears pale, anxious, and slightly diaphoretic. Now, his current vital signs, his pulse is 146, it's irregular. His respirations are 28 and labored. His blood pressure is 88/60, and his O2 sat is now 93% on 4 liters. Now, his skin is pale and cool with slight diaphoresis on the forehead. He has an irregular rapid heart rate with a S1 and S2 noted. His respirations are labored. Respiratory effort, he does have some crackles persistent throughout. Neurostatus, he is anxious, alert and oriented ×4, and his GU/GI is normal. Now, what's your primary concern right now? So, before it was his oxygen, but now what are we worried about? Okay, we want to try to stabilize him, so we're going to look at, what is that heart rate? It's 146, right? That's pretty high. He also appears to have, appears pale, anxious, and diaphoretic. So, what's your primary concern? You want to support his breathing, but the primary focus is cardiac because of the palpitations and the lightheadedness. Now, what do you think is the underlying patho cause or concern? Most likely his heart rate is caused by AFib. That's usually the most common rhythm disturbance seen in heart failure. Now, is there any more nursing assessment or data or information you need? Okay, you need to, with a heart rate of 146, the first thing you need to do, you need to get a set of vital signs. You need to make sure that you have a 12-lead EKG done. Make sure you're monitoring those breath sounds and heart sounds. Now, what is a nursing diagnostic statement that correlates with this concern? So it would be decreased cardiac output related to decreased preload. Now, what will be your nursing interventions based on this concern? You'll need to slow the heart rate through medications by either using beta blockers, digoxin, or cardizem. You're going to need to contact the physician with the S-bar once you get more assessment data. You also need to continue to stay with the patients. You also might need to call the rapid response team. You need to also obtain immediate set of vital signs and focus on the cardiac assessment of that. And as we talked about, AFib is an expected complication of heart failure. It can be. Now let's look at the patho of AFib. Basically, it's a total disorganization of atrial electrical activity. because of multiple ectopic foci, resulting in the loss of effective atrial contraction and the loss of atrial kick. And this also helps to decrease the cardiac output. Now, your atrial rate is usually 350 to 600 a minute. During AFib. So, a 12-lead EKG is ordered, and it shows that he does have AFib with a rate of 130 to 150. You contact the physician, and he gives you an order for cardizem, 20 milligrams IV push. So some things I want you to look up and know. You need to know what kind of category that cardizem is in, its action, its side effects, and any kind of nursing implications that could go on with that. Alright, so let's do another calculation. So this medication comes in a vial of 25 milligrams per 5 mLs. Now what is going to be the dose in mLs that you're going to administer? And how quickly can you administer this IV push? And also, how much volume are you going to push every 15 seconds? I'll give you just a minute to figure that out. Okay, so we know the medication comes in 25 milligrams per 5 mLs. We're going to give 20 milligrams. So that tells you that we're going to give 4 mLs. Now, how quickly can you give this medication? It's going to be over 2 minutes. You're also going to give 0.5 mLs every 15 seconds. Now, what other medical complications are commonly seen as a result of heart failure? Okay, a patient can have a pleural effusion. They could have life-threatening dysrhythmias like we talked about, such as VTAC or VFib. They could have hepatomegaly or renal failure also. So, after 30 minutes, you note that the heart rate, Mr. Kelly's heart rate is slowed to 76 and is regular. A 12-lead EKG confirms that he's back in normal sinus rhythm. Now the cardiologist adds cardizem 240 milligrams PO daily to be given right now. He diureses another 700 mLs overnight and maintains clinically stable during the night. Now, before the end of the shift, you receive the results of the labs that were ordered. So, here's his labs. We have a chemistry. The sodium is 144, potassium is 3.2, glucose is 189, your calcium is 8.8, magnesium 1.2, BUN is 35, creatinine 2.28. Lipids, the ALT is 144, AST is 225. Cardiac, he has a troponin of 0.03. His CKs are 44. CKMB is 0. His BNP is 1254. His CBC, basically his white blood cell count, is 9.5. Hemoglobin is 15.2, and platelets are 259. So, let's look at the clinically significant labs. Your creatinine of 2.28, that shows that the renal function is continuing to worsen. A BNP of 1254, that shows that the left ventricle is stressed and represents significant volume overload. Now the potassium of 3.2, is a little bit low, and this could predispose them to cardiac electrical instability, and that could result in AFib, VTAC, or VFib. Your magnesium of 1.2 is a little bit low, and this could predispose them to the same thing. Glucose 189 is a little bit high, but it's not really significant. Triglycerides of 384. That could show that he might have some arterial sclerosis due to increased lipid levels. The AST and the ALT shows that the heart failure has influenced the liver function. And he has poor perfusion to those organs, and that's increased the liver enzymes. Now, the echo that they did has a 25% ejection fraction. That shows that the heart failure is continuing to worsen and is a constant and consistent with the clinical picture. So everything's worsening with the heart failure. Now, they do some other interpretations. They're going to do a chest x-ray, and it shows a severely enlarged heart. It also shows that he has some infiltrates consistent with pulmonary edema present bilaterally throughout his lungs. The echo, like we said, showed that the ejection fraction was 25%. It shows also that there was mild anterior hypokinesis with diffuse left ventricular dysfunction. So, what radiology data above is important and relevant that must be recognized as significant to the nurse? So we know that there's, it looks like there's pulmonary edema present throughout. This is going to help guide the medical therapy. Also, the echo hypokinesis, that means there's poor wall motion movement of a left ventricle, and that could be from a prior MI or from a related new onset of ischemia. Your diffuse left ventricular dysfunction is likely reflective of a global left ventricular hypokinesis, and this could be due to progressive worsening of the heart failure. Your ejection fraction of 25%, normal is 60 to 70%, and this confirms that there's heart failure. Now, we're going to look at Mr. Kelly. We're going to prepare him for discharge. It's the next day. He's now stabilized. His vital signs are within normal limits. His breath sounds are clear bilaterally. His edema has decreased to +1 in the ankles after diuresing 1,800 mLs in the last 24 hours. Now, admission weight was 118.8 kilograms. His weight this morning was 116.8. After supplementation this morning, his potassium level was 4.0. His magnesium was 2.1. Now, he's planned to be discharged home tomorrow, so what are your nursing diagnostic priorities today? Okay, you want to make sure that you teach him about heart failure, all the things that he needs to know going home. Now, what are you going to emphasize with dietary restrictions and fluid restrictions according to heart failure management? So, a dietary is going to be the same as a hypertension. You're going to want them to eat a low sodium diet. The fluid restrictions, usually the MD is going to decide that, but they do also need to make sure they weigh themselves daily and notify the MD if there's any weight changes. Now, what's the most important education priorities that you'll reinforce with his this patient's new diagnosis of worsening heart failure? You want to make sure you emphasize compliance with all the aspects of the medical medication regime, because we know that before he was skipping days. He can't do that. He also needs to make sure that he stays on his diet and makes appropriate lifestyle changes to help with this heart failure, or it's just going to get worse and worse. Now, his current meds that he's taking, simvastatin, 20 milligrams PO daily, glyburide, 10 milligrams PO daily, HCTZ, 50 milligrams PO daily, lisinopril, 40 milligrams daily, and aspirin, 81 milligrams daily, fish oil, 1,000 milligrams, 2 tabs PO daily. Now, some new meds are going to be added: furosemide, 40 daily, and also cardizem, 240 daily. Now, the simvastatin we know he's going to be getting for his hyperlipidemia. The glyburide is going to be for the diabetes. The HCTZ is going to be for blood pressure. Also, the lisinopril. The HCTZ is going to do preload reduction, afterload reduction with the lisinopril. And the aspirin is basically going to help with the AFib to make sure that decreases the risk for any clots that could form. Also, the fish oil is going to also help lower the triglycerides. So, some things to remember: an S-bar or end of shift report. Always need to make sure that you have one of these, that you keep it updated. S stands for situation, B for background, A for assessment, and R for recommendations. Now, some things we want to discuss. Because of heart failure being a big Joint Commission having Joint Commission correlations, also Medicare, the way it pays, we want to make sure that we cover and try to, if somebody comes in with heart failure, we want to educate them as best we can when they leave, so that they're not readmitted within the next 30 days for heart failure. If a patient is discharged and is readmitted within 30 days, Medicare, most insurance companies, if they're readmitted for heart failure again, they will not pay, and the hospital will have to eat that. And what that means is basically that any raises, anything, any profits the hospital is making, it comes out of, and so that would decrease your pay. So the Joint Commission has made this one of its core measure standards. It is evidence-based practices that they found to help decrease the readmission of heart failure patients. Okay, so we're talking about the core measures. Like we said, heart failure readmissions are tied to reimbursements. So there's three core measure standards for CHF. Basically, those are discharge instructions, assessment of their left ventricular function, and also treatment of their LVSD with an ACE inhibitor or an ARB at discharge. So, let's look at each one of these individually. Discharge instructions, those are going to include their activity level. What are they able to do? What are they expected to do as far as being more active? Their diet, like we talked about, low sodium. If they're on Lasix, they might have a potassium-rich diet. Their discharge medications, those need to be gone over specifically, especially when they're going to take them, how often, and making sure that it's important that they know, especially their medications for heart failure, that they have to take those or else their heart failure will reoccur. They also need to know about any kind of follow-up appointments with a cardiologist or other doctors. They also need to know about their weight monitoring, that they need to weigh themselves daily. And if there's any changes in their weight, they need to notify the physician. Now, another part of that is what they need to do if their symptoms worsen. So, if there is a weight gain greater than 2 pounds, they need to call their physician. If they have problems breathing, they need to immediately go to the emergency room. If their edema reoccurs, they need to notify their physician. And if their heart failure symptoms return, they need to notify their physician. Now the second is going to be the assessment of their left ventricular function. Now this is going to be done by looking at a previous echo or a new echo being ordered while they're in the hospital. With an ejection fraction less than 40%, they need to be treated with an ACE or an ARB before they are released from the hospital. Now the third is the treatment of LVSD, and that's going to be done, like we said, with an ACE or an ARB. It's going to be prescribed at discharge, and that's for an ejection fraction less than 40%. Now, exclusions to that, if they have an ACE allergy, if they have moderate or severe aortic stenosis, or if there's another reason that is well documented by the physician, nurse practitioner, or physician's assistant for not prescribing the ACE at discharge. If any one of these three measures is not met, the insurance company and Medicare can refuse to pay for that admission, and also for if they're readmitted within 30 days. So, education priorities, your patient status stabilized, and now you're going to prepare for discharge and disposition home. So what's the most important education priorities you're going to reinforce with this current medical condition? You want to make sure that they know their medical regime, how often and how they'll need to take these medications. You also want to go over their diet and all the other things we talked about just a minute ago with the core measures. You want to go over their new medications. Make sure that they know exactly the rationales, the safe dosages, the action, all these different things with the new medications they're going to be getting. You need to make sure that you complete a reconciled list of the patient's medications. Make sure that that's given to the patient and or the family members at discharge. You also need to, while you're educating that patient, you need to make sure that you communicate them on a level that they're familiar with. So you need to note their developmental stage, their age, any kind of culture or preferences, any kind of level of health literacy to the way you educate that patient. You also need to know how are you going to assess the effectiveness of your teaching with this patient. So what you want them to do is to be able to tell you back. Once you teach them, you want them to be able to tell you right back what you just said, how often they're going to take their medications, what they're going to be doing. That is the most important thing. Like I said, everything is tied with reimbursement nowadays, and so it is very important that you cover all the bases if you want to get a raise later on, because there's more and more things being tied to education, how the patient is educated and how well they're being treated for their symptoms, and how well of a job that we do in making sure that these patients aren't readmitted, and that they improve their health. Now, that doesn't mean that we don't know that they're going to do what we ask them to do, but if we document that we've done these things, if we do everything in our power that we know to try to prevent them from coming back, then we've done our job. Now, that's it for congestive heart failure. There'll be several other things that'll be we'll be going over, such as PEs, PVD, basic strips. All those things will be covered with this module also.